Hello, I'm live, I'm mic'd up. I'm sorry about the shambolic audio on the last video that I did. When I wasn't mic'd up, I now can see how booming it was and won't make that mistake again. Going to talk, got a few questions here to talk about, but as ever, always happy to field questions on the fly. First of all, we're going to talk about histology. We've got a lot of people asking what histology is. It's mainly related to when you talk about moles. I've done a blog post about it, which I've just posted today, so feel free to go to the website to have a look at that. But histology is when we look at tissue or something that we remove, tissue that we remove under a microscope. So whenever we're doing any operation where we're removing a part of the body, you're always asked, do you want to send it for histology? And histology means when you send it away to the lab and a whole nother team of doctors will slice it up and prepare it and look at slithers of it under the microscope to have a look at the cells to see if there's any abnormal cells in there. So you do it when you're worried about having abnormal cells in a piece of tissue. And so the main thing comes when we're doing a mole removal. Obviously, if there's any worry about the mole, then it will have to be sent for histology. The problem comes when moles that have been there forever and you're not worried about them, but you just want to have them removed for cosmetic reasons because histology is quite expensive. Now on the NHS, I would always send moles off for histology, but in the private sector, I talk to patients, say, look, you know, it is good practice to send them off for histology, but if you've had it for years and it looks like a benign mole and there's some features that can make things look benign, benign basically means not cancerous, then it may be possible to not send it off for histology. But that's something we need to talk to you about, which is why we give free consultations, so we can talk to you about that. Broadly speaking, if it's a pigmented lesion, if it's a brown mole, those are usually good practice to send those off for histology just to be sure that they're all fine. But if it's not brown, if it's skin coloured, if it's like a hairy mole like an intradermal nevus, Rebecca shared my video. I've got to let you know I do appreciate it. I'm not sure how I let you know that I appreciate that, but it's telling me I should appreciate that from Rebecca. Thank you very much, Rebecca. I appreciate it. Do I verbally tell you that I appreciate it, or do I physically do anything? Anyway, I'm going to carry on regardless because I'm a professional. I'm not going to lose my thread. Right, is that you that's done that thumbs up or me? Okay. Anyway, I appreciate it, Rebecca. There you go, I've said it. Don't know how to do it. If I can do a thumbs up back, I would, but I'm not sure if I can. So that's why we have to discuss whether we send the mole away for histology, because it does add to the price, because obviously in the private sector you have to pay for everything. So I usually talk to patients and say, look, it's been there for years, it looks benign, doesn't have to be sent for histology. You might want the peace of mind of having it checked under a microscope, which is absolutely fine, but you might say, look, you know what, I'm fine with it. So that's what histology is, and some moles it's not optional. Some moles I'd say to you, look, you really need to get it sent off, but often it is optional, or at least we can discuss the pros and cons of it, just like anything. So then we've also got some questions about timing with regards to consultation and procedure. So there is a sort of minimum cooling off period of 2 weeks, which is sort of a BARP's recommendation that you have to have 2 weeks between your consultation and your procedure, so you have time to think about things. And then you have to look at the next date. So the next date might be whenever the next date in the diary is, which might be a month or two in advance. I'm not sure what the angle of the question was. So if you're out there and you want to chip in and telling me what your angle was, whether you want it done soon, or I don't know if you want to do it soon after your consultation, or like you want to come for a consultation and maybe have surgery in the future. So if you want it soon, 2 weeks is minimum, but then it will be delayed depending on the diary, so it might be maybe a couple of months, which I think is reasonable to give yourself time to think about things. You don't want to rush into it. It's a big decision, having sort of body contouring surgery. Hey Dawn, saw that, and can I do anything? Oh god, delete comment. No, don't want to do that. Anyway, sorry, I don't know if I can do a hello. Anyway, sorry. I'll just say hello. So, yeah, the minimum time, 2 weeks, is a sort of industry sort of thing, and then until the next appointment. But I would say, look, it's a big deal having this sort of surgery. You need to think about things. Often people have researched it to the hilt and they know everything. And so, I understand how they might want it done quicker. But if you, often people haven't, researched it so much and haven't seen before and after photos of real people and gone into the ins and outs of it. So you really need time to consider it. So I would say take as long as you need. And that's why we don't charge for follow-up appointments, because I always say to people, look, come back and have a think about it, come back. The longer you leave it, the better, really. Once you've decided to have surgery, you can't really, go back, but you can decide to have surgery at any time. So the longer you leave it, the better. And if it is going to be a long time, if that's the angle of the question, it's, you're thinking having surgery a long time in the future, then you can always come back for another consultation, closer to the time, and there's no charge for that. So you only pay for the first consultation. So you can do that. But if it is definitely going to be in a long time in the future, it might be worth delaying your consultation. But sometimes people like to get a consultation in so they've got an idea what they're dealing with, if surgery is realistic. And so I understand that. So you're more than welcome to come for a consultation. We can go over everything, and then you might want to say, look, I want it next year or whatever. You get that quite a bit. People having the surgery a year later or something, that's absolutely fine. Just, but you would probably best come back closer to the time to discuss that. And that brings me nicely on to the other question, which we've had just in after my last booming Facebook Live video. So that obviously was good, because then we've got a question about revision surgery and sort of timing for revision surgery. This is someone who's had problems. It's not my patient. I think she's just inquiring for me because she's lost confidence with the original surgeon. Had a lift. I think a lift with implants, and then, or maybe had the implants removed and then had the lift redone. Sorry, I can't remember the actual details of it, but essentially it's a lift. Bad scarring from the lift, bad shape from the lift. I think it's already had one revision, not got the result that you want, and I understand that you're keen to have to see someone else. So yes, I'd be very happy to see you and we can talk about things, but you only had your surgery in March, so I've done a bit of direct messaging about it. But yeah, I think probably it is best to wait, and the longer you wait the better, especially when you're dealing with shape and scarring, because those things settle and you don't want to keep on having revisions, keep on chasing something that's continually moving. I normally say things start to settle around 3 months, and they can take 6, 12, even 18 months. There you go, implant. I'd like to thumbs that up, but I don't know how to do that, but maybe one day I'll know. But yeah, implant removal and lift. You need to wait to get the best result possible from the last operation, really. Things won't start to settle to around 3 months, which is actually about now, isn't it? So maybe things will be starting to settle, but your scars will still be red. So I'd say to you, start massaging your scars with cream. I've got to say, it's always good to really try and stay close to your original surgeon. I know you may be looking for other opinions, but I'm sure they'll try and get the best result out of their last operation that they possibly can. So I would say, do stay close with them because they know what they've done. Massage your scars with cream. Things will settle, the shape will settle, will change. And what I normally say to people is that leave it as long as possible. It may not change to your satisfaction and you may need a revision, but it will change. And so the result will be different in a year's time to how it is now, or in 6 or 8 months' time, it will be different to how it is now. And so, that don't make any long-term decisions on how it looks now. And I know it's difficult when you've had multiple revisions already. The other thing is revision surgery is difficult because revision surgery is dealing with scars. All we do as plastic surgeons is create, any surgeon creates scars. That's all we can do. Anytime we do anything to anyone, we create scars. And often people will come to plastic surgeons for scar revision, and there are things we can do to revise scars and to make scars better. But we are creating new scars. We just got to hope that our scars are better than the other scars. So I think if you've got sort of thickened, lumpy scarring, there is a risk that they may get thickened and lumpy again. If there's a reason that they're thickened and lumpy, so if there was delayed healing for the wound first time, then that's a good sign. It might be they might be thickened and lumpy because of the delayed healing, rather than your body's tendency to form thickened and lumpy scars. Because some people have a tendency to form thickened and lumpy scarring. You can keep on going. You can keep on going and doing revisions, and they keep on getting thicker and lumpy, and actually it's your body's tendency to form the lumpy scarring rather than the rather than it's actually the surgical procedure. I'm hoping I can get these comments back. Yes, I can. Yeah, thanks Dawn for your vote of confidence. Awesome that yours look good. I'm very pleased about that. And Rebecca, I'm going to read that in a minute and answer your question. But this is great, getting interaction. This is dream. Yeah, if there's a reason for you to think thick and lumpy scars, then that would actually be a good thing. So the other thing, when you have thick and lumpy scars, there are things you can do. I mean, massage is good. Silicone sheets are good. A lot of people rate silicone sheets for all scars, or silicone sheets or silicone gel. But on the breast, sheets are good. The gel seems to be very popular at the moment. Things like Dermatix Sil Gel, Silgel. I think you can buy it in the pharmacy. It is quite expensive. For the gel, when the gel first came out, it was really for sort of things like faces and places where the sheets would just fall off. But it seems to have taken hold, and I think I can understand why, because it's a lot easier to put the gel on. But I think the sheets are more effective on areas like the breast and the abdomen, and places where they will, because they're sort of sticky, so they will hold on. So silicone sheets might be worth looking at to try and make the scars as good as they can possibly be, and let the shape settle as much as it possibly can before considering a revision. If you want to come and see me, you can come and see me any time, but I will probably say to you, wait at least a year before your revision. So it might be worth waiting until sort of the end of the year, the end of this year, because it was March this year, wasn't it? So or sort of early next year. But as I say, if you want to come, I'll see you anytime. I only charge for the initial consultation, so we can always talk about what's achievable, and then I'll see you again later on. It's totally up to you, but I'm really sorry to hear you've had so many problems. And the other thing I say to people is minimize the amount of operations on your breast. You've already had, I don't know, 2 or 3 or a few operations on your breast, so you've got to minimize the amount of operations on your breast. So, I probably will be trying to get you to leave it as long as possible, I think, by what you've said, because you've already had a few operations. I say, look, leave it, if you can even leave it even longer in the year. And it might be that it'll get to the stage that it is maybe acceptable to you, because it gets more and more difficult every time you create scarring on the breast. So you don't want to have too many surgeries to the breast if you can help it. Rebecca, we've got a live question coming in here from Rebecca. Rebecca says, "Hi Jonathan, I don't know, you can probably read this yourself, can't you? Can you tell me how long an operation, so how long an operation, I guess, would take to remove implants with capsule contracture and do an uplift, and would implants be better behind the muscle?" Thanks, awesome question, Rebecca, loving that. And if I knew how to do thumbs up, I would do it. I can delete that, but no, okay. So I'm going to oh God, sorry. That was, there you go. Oh God. That was a real time thumbs up, which clearly I should probably avoid doing in the future. Anyway, Rebecca, right. Okay. People always want to know how long an operation takes. Does it matter how long an operation takes to you? I mean, I guess broadly speaking, it matters, but you're asleep for it. But anyway, I understand. People outside and things, they want to know how long an operation takes. That's quite a big operation you got there, Rebecca. Removal implants, capsular contracture, and an uplift. So the removal of implants bit, if you're doing capsular contracture and an uplift, then the removal implants bit sort of is a small part of it. The main time is going to be coming on the uplift, and that's about 3 hours. Rebecca, is for an 2.5 3 hours for that operation. Probably be a little bit longer if you're having your implants replaced. You don't. You are having your implants replaced. You're saying would be better behind the muscle. So okay, well yeah, 3 hours in that case if you're having your implants replaced. Because that is quite a big operation. A breast lift and implants is a big operation because a breast lift tightens the skin and implants tighten the skin. I don't know where you're going with the size, whether you're going upsizing, downsizing. But certainly if you're upsizing, you know, you're tightening the skin and all that sort of thing. For that reason, a lot of people do lift with implants in 2 stages, especially if you're upsizing, because upsizing your implants will take up some of that slack skin that the mastopexy would have tightened. And so if you're upsizing, it might be worth, you know, depending on how much bigger you want to be, you could think about just having the implants first and seeing whether you're happy with it. And then considering having the lift later. Similarly, if you're downsizing, you could consider having the implants removed and not replaced, and just have a mastopexy. And if you're not happy with it at a later date, having the implants put in. But you know, you can talk about that. I do a lift with implants in 1 operation, but I warn everyone it's got a high complication rate because you're making everything tight with the lift, and then you're making everything tight with the implants. So it is something not to be taken lightly. So it would be reasonable to stage it. Some surgeons routinely stage it. So you're looking at 3 hours of surgery, but I always say to people that there's more to it than just the surgery, because you come to the operating theatre, you get anaesthetised in the anaesthetic room, you then get taken into the operating theatre, you then get prepped and draped. So we have skin preps, and then you drape you. Then we do the operation, which is like the 3 hour bit. Then we put the dressings on, take the drapes off, wake you up, you usually wake up in the operating theatre, although you don't usually remember that. Then we transfer you back to the recovery, which is a ward within the theatre complex, and you're in recovery for anywhere between half an hour to an hour just to get you comfortable before you go back to the ward. So if you have got people outside waiting for you, I always say, look, don't panic if you're away for more, you know, an hour or more time, because it may not necessarily mean that the operation's taking all that time. It may just be the bits on either side of it. Would implants be better behind the muscle? Well, that's the $1 million question, isn't it? A lot of people say that implants are better under the muscle, or they're better on top of the muscle. The fact of the matter is we put implants on top of the muscle and under the muscle. So if one was better, well, we wouldn't do it the other way. So if the implants were better under the muscle, then no one would put them on top of the muscle. A lot of literature about implants is from America, and they put implants under the muscle a lot more often in America than we do in the UK. I think that's because for a long time in America they weren't allowed to use silicone implants. They were banned for many years, so they only use saline implants. And saline implants pretty much always have to go under the muscle because you would see rippling and you'll see the edges of them. So they do use silicone implants now, but I think from what I've read from American surgeons, they seem to do a lot of implants under the muscle, certainly more than we do in the UK. Having said that, so what I normally say to people is there's good and bad about putting them in front of the muscle, good and bad about putting them under the muscle, and you have to weigh up the pros and cons to which one's best for you. The good thing about putting them under the muscle is it hides the implant, because the muscle gives it an extra layer of cover. So if you're very slim, particularly if you can see your rib cage, if you're very slim, and you haven't got a great deal of coverage over your breast, if you've not got much breast tissue, then you'd worry that you'd be able to see the edges of the implants, you'd be able to feel the edges of the implants, you might get visible rippling of the implants, and so all those things would mean that you'd want to hide the implant under the muscle. So in those circumstances, yes, the implants are better behind the muscle, but there are more complications with putting implants underneath the muscle. It's more painful when you put the implants underneath the muscle. It bleeds more. There's more risk of a hematoma when you put the implants underneath the muscle. So the recovery is slower. And also, because you're cutting the muscle, it hurts every time you move, and the implants can be held up high by being put under the muscle, and sometimes the implants can be held wide by putting underneath the muscle. Whenever you see that very abnormally wide cleavage, it's pretty much always with implants underneath the muscle. So that's not a good look. So therefore, it's not better if your implants sit high or wide. Now, you're not saying they will sit high or wide, it's just an increased risk when you put them under the muscle. Also, you get something called animation deformity. So if you do a lot of exercise in the gym and what have you, you can get the breast moving when you're moving your arm, because the breast is or the implant is underneath the pec major muscle. So every time you move the pec major muscle, the breast moves, and that can be unsightly. So there are reasons not to put it underneath the muscle. So that in those circumstances, it would be better to put it on top of the muscle. So it all comes down to how much coverage you got over your chest as to whether that balance of risks are. So there's bad things about putting it under the muscle, and there's bad things about putting it on top of the muscle, and there's good things about both. It's just balancing them up. But that is an awesome question, and I'm very pleased to have got that live during my chat. Hold on. Right. Oh God, sorry, I'm not sure what's. Okay, just going through my comments here. I think I'm done. I pinned that. Sorry, I've pinned that. Okay. Right, I am now 5 years and still have quite a lot of numbness around the right side and going around to my back. Is this normal, and how long should it take to come back? It feels weird. I'm going to guess that's weird. I think that's pretty much, I think that's a fair assumption. Dawn, 5 weeks is nothing. It's nothing. Don't worry. Don't worry. Hi, Freds. Yeah, Freds, I'm doing the live video. So can yeah. Yeah. All right. So 5 weeks. Yeah. Okay, Freddie. 5 weeks is nothing. So don't worry about 5 weeks post-op. That's absolutely fine to have that funny feelings. Yeah, absolutely fine, Dawn. So I wouldn't worry about that at all. And please, Feds, thank you. Right, so 5 weeks is absolutely fine, and I wouldn't worry about that. That's fine. Everyone gets numbness at 5 weeks, and the thing I'd say to you is you've had a big op, Dawn, and there may be some residual sensory issues, but we wouldn't know that until about a year post-op, 9 to 12 months post-op. A lot of people get this sort of numbness and weird feelings in the first few months, and it often will get better. Again, a bit like the revision thing, I'd say to you it's going to be different at a year. I'm hoping it'll all be fine and it'll all be better, but it will be different. But the bottom line is, don't worry about it at this stage, because it will change, and I hope it will get better. It might not. I'm not guaranteeing that it will, but it will definitely change, and it usually does actually get better. And a lot of people have problems early on, don't really get any problems late on, and I think that's either because the sensation comes back, or people can't get used to the funny feelings, and they're not quite so much of a problem. So I wouldn't worry too much about that, Dawn. But if you are worried, obviously, come on down to the clinic and I'll see you. But I'm not worried about that. That's a normal thing, the numbness and what have you, especially with such a big op. Oh, yeah, my son, yeah, thank you. That's good, isn't it? Getting him on. I'll have a stern word with him in a minute. Oh, you're coming to see me tomorrow, Dawn? Okay. Okay, I'll see you tomorrow. Right, I think I've got to go and have words with my son, and he's obviously disobeyed my strict instructions not to bother me. But there you go. Right, so sorry about that, and I am gonna. I think we're done. Are we done? Yeah. I think we're. Oh God, dear, sorry. I think we're all done, and I'm going to check out and have a lovely evening, everybody, and that's really good. Thanks very much for all the comments tonight, and do the same thing next week at 7 o'clock. Oh, actually, I'm on holiday. I'm on holiday next week, so I might not do it next week. So that'll be even worse than tonight, actually. So it might be on holiday for 2 weeks. Anyway, I'll let you know when I'm doing it next time. It might be 3 weeks' time. Extravaganza then, so many questions there, weren't they? So yeah, it's been really good tonight. Thank you very much, and I'm going to check this one out because I think I'm all done with the questions. I'm hoping I am. I often see questions afterwards, which I regret, but I don't. It's just I think I've done what I can see here. So thank you very much. Hopefully next time I'll be able to thumbs you up in a Facebook style, because I clearly haven't been able to do that in this tonight. Oops, I can write a comment. Okay. And I'm going to check out. Thanks a lot. Good night. Bye.